Welcome to part 2 of my lesson on hyponatremia. In part 1, I reviewed the pathophysiology and etiologies, so now I'll cover the consequences and treatment. When it comes to consequences of hyponatremia, we're asking ourselves two main questions. Why is hyponatremia life-threatening or deadly? And at what serum sodium level do major complications occur? I highlighted the answer to the first question in part 1 when I compared and contrasted hyponatremia and hypernatremia. With hyponatremia, the low sodium concentration sends water into the cells and causes them to swell. That shift results in mostly neurological consequences because of its effect on brain cells. In the most severe cases of hyponatremia, the brain cells swell until they burst, and that's what causes profound neurological damage or death. Transitioning to the second question, which refers to the sodium level that major complications occur, we see hyponatremia is classified as mild, moderate, and severe. Mild hyponatremia is 130 to 134 milliequivalents per liter. Moderate hyponatremia is 125 to 129 milliequivalents per liter. And severe hyponatremia is less than 125, though some authors present these with some slight variations. Mild hyponatremia is associated with irritability, headache, and difficulty concentrating. Moderate hyponatremia is associated with nausea, confusion, lethargy, and issues with balance and coordination. And severe hyponatremia is associated with vomiting, seizures, coma, permanent neurological damage, and death. So, significant complications occur almost exclusively with the serum level less than 125 milliequivalents per liter. Nevertheless, as we examine these consequences, we must also consider whether the hyponatremia is acute or chronic, which is delineated by 48 hours. That's because the brain undergoes an adaptive process in chronic cases that normalizes brain volume and makes a person more resilient to some complications. As such, patients presenting with mild to moderate chronic hyponatremia may present as asymptomatic. However, these cases are still concerning because mild chronic hyponatremia in older adults is associated with cognitive deficits, gait disturbances, and an increased risk of falls and fractures. Hyponatremia is even considered a secondary cause of osteoporosis because it enhances bone resorption and inhibits the deposition of new bone material. Whenever the duration of hyponatremia is unclear, chronic hyponatremia must be assumed. Understanding the clinical manifestations, duration, and severity of hyponatremia is critical as we transition into our final section on treatment. That's because the urgency of treatment and appropriate sodium correction rate depends on these factors. A severe case with moderate to severe symptoms is a medical emergency, requiring hypertonic intravenous fluid to rapidly increase the sodium concentration. Meanwhile, a mild to moderate case with no symptoms or mild symptoms is a far less pressing matter and calls for an etiology-based intervention where the cause dictates the treatment strategy. Considering the role of a registered dietitian on an interdisciplinary team, there's little room to have a meaningful impact on hyponatremia in the early stages of a severe symptomatic case. However, etiology-based interventions offer tremendous opportunities to make a difference since most patients will benefit from an individualized diet prescription, nutrition education, and nutrition counseling. First up, we'll look at emergency treatment. Once again, this is for severe symptomatic cases that require swift action from a physician, so a registered dietitian isn't usually responsible for knowing how to treat it. Nevertheless, it's helpful for dietitians to know at least a little bit about it because it can help us better understand the patients we encounter in the inpatient setting. In these cases, the goal is to quickly draw water out of the brain cells and minimize or prevent complications. The best way to do this is with a 3% sodium chloride solution. After all, as a hypertonic fluid, a 3% sodium chloride solution increases the solute concentration of the intravascular space, and water flows from the area of low solute concentration to the area of high solute concentration to establish equilibrium. Currently, the recommended protocol in the United States is to provide a bolus of 100 milliliters over 10 minutes up to 3 times to increase the serum sodium level by 4 to 6 milliequivalents per liter. So, a bolus of 3% sodium chloride is administered, the serum sodium is monitored, and this process is repeated until the sodium increases by 4 to 6 milliequivalents per liter, which is sufficient to alleviate brain swelling and improve neurological symptoms. For patients with acute hyponatremia, the serum sodium can continue to rise throughout the day without concern for the rate or total increase in sodium concentration. Yet for patients with chronic hyponatremia, interdisciplinary team members must pay careful attention to both factors. That's because the same adaptive process that normalizes brain volume and protects the patients from complications also predisposes them to cell shrinkage and rupture from treatment with a hypertonic fluid. Thus, for chronic cases, sodium correction should not exceed 12 milliequivalents per liter over 24 hours or 18 milliequivalents per liter over 48 hours. For patients at very high risk of complications, including those with a sodium concentration less than 105, hypokalemia, alcohol use disorder, advanced liver disease, or malnutrition, sodium correction should not exceed 8 milliequivalents per liter over 24 hours. In the event of overcorrection, the recommendation is to carefully lower it to the correction limit by administering hypotonic fluids or giving desmopressin, which is a synthetic analog of arginine vasopressin. A continuous infusion of a 3% sodium chloride solution is sometimes used instead of a bolus infusion. Still, the bolus method has been shown to increase serum sodium by 4 to 6 milliequivalents per liter faster and is less likely to overshoot the target. After the initial increase in serum sodium and alleviation of neurological symptoms, the treatment for hyponatremia begins to track with the etiology-based care seen for mild to moderate cases with no symptoms or mild symptoms. Identifying the etiology is paramount to improving the sodium level, avoiding the disorder's progression, and minimizing the risk of complications. Moreover, failure to correctly identify the etiology can lead to a treatment strategy that makes the hyponatremia worse and increases the risk of complications. I've seen multiple flowcharts published to help clinicians sort this out. Most of the time, they begin with a step that helps to identify whether the hyponatremia is hypertonic, hypotonic, or isotonic. This is best accomplished by examining serum osmolality, which measures the concentration of the blood. The normal serum osmolality is 275 to 295 milliosmoles per kilogram, so if it's within that range, it suggests isotonic hyponatremia. If it's above or below that range, it suggests hypertonic hyponatremia and hypotonic hyponatremia, respectively. When the serum osmolality points to isotonic hyponatremia, the patient should be evaluated for hyperlipidemia or hyperproteinemia. Once that underlying issue is treated, the serum sodium level will increase. Similarly, if the serum osmolality points to hypertonic hyponatremia, then the contribution of hyperglycemia or a recent mannitol infusion should be obvious. Since serum sodium decreases approximately 1.6 milliequivalents per liter for every 100 milligrams per deciliter over 100, the correction of hyperglycemia with insulin will cause an increase in the serum sodium level as well. The treatment of hyponatremia gets a little trickier when it's hypotonic hyponatremia, which is where an investigation of the serum osmolality is most likely to lead. Determining whether hypotonic hyponatremia is hypervolemic, hypovolemic, or euvolemic can be accomplished through any combination of performing a physical assessment, measuring vital signs, and reviewing the patient's past medical history, active problems, and medications for possible causes. A patient with hypovolemic hyponatremia is expected to present with dry mouth and eyes, poor skin turgor, low blood pressure, a rapid heartbeat, and either a noticeable loss of fluid and electrolytes, diuretic use, or suspected adrenal insufficiency. A patient with hypervolemic hyponatremia is expected to present with edema in the arms, legs, or abdomen, and a history of heart failure, cirrhosis, or renal failure. And a patient with euvolemic hyponatremia may not have any positive physical signs of hypovolemia or hypervolemia, but are on a thiazide diuretic, have a malignancy, respiratory disorder, central nervous system disorder, or medication that is known to cause SIAD, or have a known alcohol use disorder or low solute diet. There's no surefire objective way to distinguish these groups, and it's more about putting together the pieces of a puzzle. Assessing the urine osmolality and urine sodium concentration can be another valuable piece of that puzzle. If the urine osmolality is less than 100 milliosmoles per kilogram, it suggests that the urine is maximally dilute and that arginine vasopressin is not involved. That can be used to identify renal disease, excessive water intake, or a low solute diet as possible etiologies, while excluding etiologies like heart failure, cirrhosis, SIAD, and renal or extrarenal water and sodium losses, where overactivity of arginine vasopressin is expected. Furthermore, the urine sodium will help to distinguish between renal and extrarenal losses for hypovolemic hyponatremia and between heart failure, cirrhosis, and renal disease for hypervolemic hyponatremia. For hypovolemic hyponatremia, urine sodium that's greater than 20 milliequivalents per liter suggests the kidneys are wasting sodium, which occurs with diuretics and adrenal insufficiency. Urine sodium less than 20 milliequivalents per liter suggests the kidneys are conserving sodium, which occurs when there are extrarenal losses like diarrhea, vomiting, or sweating. Then, for hypervolemic hyponatremia, urine sodium greater than 20 milliequivalents per liter is indicative of renal failure, whereas urine sodium less than 20 milliequivalents per liter suggests heart failure or cirrhosis. The urine sodium for etiologies related to euvolemic hyponatremia is usually greater than 20 milliequivalents per liter. Once the specific type of hypotonic hyponatremia is determined, the actual treatment of it can begin. One of the significant steps here is to treat the underlying cause. Some examples include a patient with bacterial pneumonia contributing to SIAD who requires antibiotics, A patient with adrenal insufficiency who requires hormone replacement therapy, and someone with end-stage renal disease who requires hemodialysis. Treating the underlying cause will improve the serum sodium level and help to prevent it from recurring. Generally, though, changes to fluid and electrolyte administration will also be needed to help bring the serum sodium level back to within the normal range. Patients with hypovolemic hyponatremia require an increase in fluid and sodium. That typically takes the form of an isotonic intravenous fluid, like a 0.9% sodium chloride solution. Still, in some situations, it may just include increased oral fluid intake with an emphasis on high salt foods and beverages or the provision of salt tablets. Patients with euvolemic hyponatremia require a fluid restriction. High salt foods and beverages or salt tablets can be added as a second-line therapy if this does not sufficiently increase the serum sodium level in patients with SIAD, a cortisol deficiency, or thiazide-induced hyponatremia. Those with a low solute diet will need a simultaneous increase in solute from sodium, potassium, and protein. Finally, patients with hypervolemic hyponatremia require a fluid restriction, and in some but not all publications, a sodium restriction is recommended too. A physician also has options for medications to restore fluid and electrolyte balance. Examples include urea and vaptins for euvolemic hyponatremia, and diuretics for patients with hypervolemic hyponatremia. Keeping up with the honorable mention of hypokalemia as an etiology for hyponatremia, potassium repletion can help to increase the serum sodium level by sending water into the cell and pulling sodium out of it. In some situations, potassium repletion can be sufficient for bringing the serum sodium level back within the normal range. For patients with severe symptomatic hyponatremia who also have hypokalemia, special attention must be paid to the sodium correction rate, as potassium repletion may lead to a faster increase in serum sodium than is expected for the amount of hypertonic sodium chloride administered. Etiology-based treatment ends up looking like this. For all types, you want to address the underlying cause. Then under hypotonic hyponatremia, you restrict fluid and sodium when it's hypervolemic, replete fluid and sodium when it's hypovolemic, and restrict fluid when it's euvolemic. Euvolemic also sometimes requires salt repletion, and when it's a low solute diet, an increase in sodium, potassium, and protein can be beneficial. Lastly, when there's hypokalemia, potassium repletion can help with hyponatremia. Within this algorithm, one of the biggest challenges is differentiating between hypovolemic and euvolemic hyponatremia. One technique for figuring it out is administering a small amount of an isotonic sodium chloride solution. If it's hypovolemic hyponatremia, the serum sodium will improve. In most cases, if it's euvolemic hyponatremia, the serum sodium won't improve and may even worsen. So, some risk is involved, and doing this is only sometimes recommended. If you're enjoying this video so far, make sure you check out my book, which is now available in my store and on Amazon. I left links for it in the video description and comments section. The last two questions I want to explore in this video are: to what degree should fluid and sodium be restricted, and how often should the serum sodium be monitored? First, looking at fluid and sodium restrictions, there doesn't appear to be a broad consensus on how to apply them to all cases of hyponatremia. For instance, recent guidelines from the American Academy of Family Physicians suggest 500 milliliters to 1 liter of fluid per day for patients with euvolemic hyponatremia, 1 liter per day for patients with hypervolemic hyponatremia from heart failure, and 750 milliliters per day for patients with hypervolemic hyponatremia from cirrhosis. However, organizations like the American Association for the Study of Liver Diseases will present their own disease-specific fluid recommendations. For cirrhosis, they recommend no fluid restriction when the serum sodium is greater than 126 milliequivalents per liter, a fluid restriction of 1 liter per day when the serum sodium is 120 to 125 milliequivalents per liter, and a more severe restriction when the serum sodium is less than 120, though they don't specify what it should be. Elsewhere, the most common suggestions I've seen are to either restrict fluid consumption to 1 liter per day or use the Furst equation ratio to guide fluid recommendations. This ratio is determined by adding the urine sodium and urine potassium concentrations and dividing them by the serum sodium level. If the result is greater than 1, a more stringent restriction of around 500 milliliters per day is warranted. If the result is less than 1, then a less stringent restriction of approximately 1 liter per day should get the job done. I'm personally not a fan of imposing strict fluid amounts, particularly in patients with multiple comorbid conditions, because it can lead to feelings of deprivation and reduce overall energy intake while only having a limited effect on the serum sodium level. Thus, imposing a severe fluid restriction on a person with already low appetite and intake can further deteriorate their overall nutritional status and well-being. In my practice, I'm less inclined to follow something like the Furst equation ratio. I'm more likely to restrict to around 1 liter per day and see how far that goes while other supportive treatments have time to take effect. A similar situation presents itself for a sodium restriction in the context of hypervolemic hyponatremia. Though many recent review papers mention sodium restriction as a component of the treatment plan for this type, they fall short of specifying the amount and sometimes warn about the potential negative consequences to the patient's nutritional status by imposing one. After all, sodium is a potent flavor enhancer and is plentiful in many high-calorie food options that may be useful for a patient with end-stage renal disease, heart failure, or cirrhosis when their appetite is low. While I'm unaware of any specific sodium restrictions for hyponatremia, the Academy of Nutrition and Dietetics recommends 2,000 to 3,000 milligrams per day for patients with heart failure, and the National Kidney Foundation recommends less than 2,300 milligrams per day for patients with end-stage renal disease. Notably, these recommendations hardly deviate from the Dietary Guidelines for Americans, which recommends less than 2,300 milligrams per day for healthy adults. So, while many papers cite the sodium restriction, it's prudent to conclude that somewhere in the 2,000 milligrams per day range is appropriate. The final piece I wanted to touch upon is the monitoring of serum sodium. With the severe symptomatic cases, we saw the need for monitoring after each bolus of the 3% sodium chloride solution to assess the need for another round to achieve the initial 4 to 6 milliequivalent per liter increase that has been shown to improve brain swelling and symptoms and prevent further complications. So, monitoring of serum sodium should happen every 1 hour or less. Once the initial increase in the sodium concentration is achieved, monitoring can become less frequent. With chronic hyponatremia, where special attention must be paid to the sodium correction rate, Switching to approximately every 4 hours can be helpful to avoid exceeding the recommended targets for the 24-hour and 48-hour timeframes. With acute hyponatremia and less severe cases, where the risk of complications from rapid correction is low, the frequency can be every 12 hours until it's above 130 milliequivalents per liter, and then every 24 hours after that. As we saw with fluid and sodium restrictions, there isn't a strong consensus on these monitoring frequencies. There are some differences depending on which publication you read, and there's likely greater variability from institution to institution, and even down to the individual clinician's preference and philosophy. In summary, hyponatremia is defined as a serum sodium level less than 135 milliequivalents per liter. Etiologies for hyponatremia are typically classified as hypertonic, hypotonic, or isotonic, with hypotonic hyponatremia being the most common type that's further classified by extracellular volume status. Correctly identifying the type of hyponatremia present is paramount to the treatment of it because different etiologies require different treatment strategies, and providing the incorrect intervention can worsen the condition. Currently in the United States, the recommended protocol for treating severe hyponatremia of less than 125 milliequivalents per liter is to provide a bolus of 100 milliliters of a 3% sodium chloride solution for over 10 minutes up to 3 times to increase the serum sodium level by 4 to 6 milliequivalents per liter. For chronic cases of hyponatremia, total serum sodium correction should not exceed 12 milliequivalents per liter over 24 hours or 18 milliequivalents per liter over 48 hours, unless the patient is at very high risk of complications, at which point correction should not exceed 8 milliequivalents per liter over 24 hours. Once the initial increase in serum sodium is achieved and symptoms improve, the focus shifts to etiology-based treatment. The etiology-based treatment of hypotonic hyponatremia involves treating the underlying cause and adjusting fluid and electrolyte administration, including fluid and sodium repletion for hypovolemic hyponatremia, fluid and sodium restriction for hypervolemic hyponatremia, and fluid restriction for euvolemic hyponatremia, though euvolemic hyponatremia may also require sodium repletion. Thank you for watching. Don't forget to like the video and subscribe to the channel.